So I wanted to talk about a Minute Medic that I made recently that was deleted. Shocking. Now I know there's community guidelines and I don't want to break any of TikTok's rules, but I found that video on TikTok and it's still there and it's got 23 million views. And of course mine gets flagged and removed. It was the Minute Medic where the guy gets hit by a motorcycle and has head trauma. Yep, that's the one. So if you remember the call, the guy was unresponsive and he had his helmet on and he had trismus. He couldn't open his mouth to perform an advanced airway. Seeing that this is an obvious trauma alert, we need to limit our on-scene time. Remember, on-scene time needs to be limited to under 10 minutes. This guy's going to need spinal motion restriction. And because we have airway management issues, the helmet needs to come off. Now, how did we know that it was head trauma? Let's take a look at these vital signs again. So something here needs to jump out at you. We got a hypertensive patient with bradycardia and irregular respirations. We call this Cushing's triad. You get to see this with brain herniation. Now, brain herniation is seen with ICP. A couple other honorable mentions here. Look at that end-tidal capnography of 62. Yeah, not good. And also the SP2 of 76. This patient needs to be ventilated ASAP. Now, before I get to even managing that airway, there's a couple things that we can do for this patient. First is we can elevate the head 15 to 30 degrees. By doing so, this can assist with draining the cranial vault and reduce ICP. Next, we have to make sure that we have an end-tidal capnography of 30 to 35. I know 35 to 45 is normal, but we want to be in the range of 30 to 35. Remember, you never want to drop below 25 because that can increase mortality. So we have a couple options for airway management. First, we can go ahead and use paralytics to try to help relax that trismus. All right. If you do not carry paralytics, which I'm sure a lot of you providers may not be carrying, you're going to have to correct that patient. Now, once we get that patient intubated, we need to make sure that we get that end-tidal capnography down, right? It was in the 60s. We need to bring it down to 30 to 35. So you're going to have to hyperoxygenate that patient one breath every 3 seconds until you get your desired CO2. Now, for the providers that threw out the use of mannitol, mannitol should not be used in this setting because we don't know if there's an active bleed. There needs to be a CT scan first to confirm that there's no bleed. Remember, mannitol is used for cerebral edema. Big difference. Let me know if you have any questions.